Okay, good morning to those of you joining us or who have joined so far. Welcome. We're going to get started in just probably a minute or two. I know people are still grabbing coffee, finishing up lunch, or something else entirely, depending on what time of the day it is for you. So we'll get started in just another minute or two. But you are here, if you are here for integrating gender-affirming care into medical education, you are in the right place. And thank you for joining today. So again, we're just going to give it about a minute, and then we'll get started.
So excited to be talking about this topic. I didn't learn anything about this really in medical school or residency at all. So I think this is such an important medical education topic to make sure that everybody has skills.
Well, we're so excited to hear you talk about it today, Dr. Chiaramonte, and so grateful to those of you who are interested in expanding your own knowledge about this topic or diving into the conversation that we're going to have today about the topic. So thank you again so much to those of you who are signed in or those of you watching on the recording. Thank you for being here today and for your interest in this topic. I'll get started with a little bit of our housekeeping just while we wait for some other people to join. So welcome to this McGraw-Hill Masterclass on integrating gender-affirming care into medical education. My name is Kaylin Creason. I'm a customer success librarian with McGraw-Hill. I'll be facilitating the webinar today with help from one of our marketing managers, Erin Smith. We'll be available in the chat. So if you run into any technical difficulties or anything like that, please feel free to just put that message in the chat. This webinar is being recorded, so if you have to drop out at any point, anyone who registered for the session will get a link to that recording. That usually takes about a day or two just as we wait for the recording to process. So probably won't get it by the end of the day today, but certainly by probably Monday of next week. Again, I'll mention that the chat is open. We totally encourage questions, conversation during this webinar today. I'm really excited to hear from all of you. I know Dr. Chiaramonte is too. I know we all have a variety of experiences with this topic. And I know we're all going to do our best to ensure that the chat is just like a really supportive, amazing place of sharing like knowledge and professional experience. So I'm excited to hear what all of you have to say. And I'm especially excited to hear what Dr. Chiaramonte has to say. So with that, I will introduce our excellent speaker. Dr. Delia Chiaramonte is a physician and medical educator who is board certified in family medicine and palliative medicine. She is a part-time assistant professor at Johns Hopkins University School of Medicine, where she teaches in the Palliative Medicine Fellowship, and an adjunct assistant professor at the University of Maryland, where she teaches multiple asynchronous courses for medical learners. She's also an executive medical director, she is also an executive medical editor for McGraw-Hill. Dr. Chiaramonte's prior positions include Division Chief of Palliative Medicine at Greater Baltimore Medical Center and Director of Education and Associate Director of the University of Maryland School of Medicine Center for Integrative Medicine, where she taught medical students for a decade. She has also served as residency faculty for a family medicine residency. Dr. Chiaramonte has been voted a top doctor by her physician peers and has published multiple textbook chapters in the fields of pain management and palliative medicine. So with that, thank you for being here, Dr. Chiaramonte, and please take it away.
Thank you so much. I'm really excited to talk about this topic because as someone who has worked for a long time in palliative medicine and integrative medicine, connection and communication with the patient and family is so important. And this is a place, this idea of gender-affirming care that I didn't learn about in medical school, in residency. And it's a place that we can inadvertently really emotionally hurt our patients, and we may not even have any idea. So I think the fundamental concept here is that this is not for a niche group of people. This is for anybody providing clinical care. And so faculty who are bringing up the next generation of doctors, my hope is that this really becomes integrated into the education around communicating with patients, because it is, in fact, so important. All right, let's see. Okay, so just to start us off, first I want to second what Kaylin said, which is that we all bring different experiences to this topic, and there may absolutely be people on this call who have more experience, a different experience than I do. And so I really encourage everybody to share their perspective. And if I inadvertently say something that doesn't sit right or feels offensive, please know that I apologize, and please let me know, because we're all learning, including me. I hope that we'll use the chat to have a really respectful and open communication. And I do also want to just recognize that as a cisgender woman, I'm not the ultimate expert in any way on the transgender experience. I acknowledge that, but we have to start the conversation somewhere. So I see this as the first level of a conversation so that we all have terms that we understand, and we can take this conversation even more deeply in the future with a wider group of people and perspectives. But I'm glad you're here. Okay, so truth number one is that gender is not determined by our genitalia, and it's not determined by our chromosomes. So this is something that really confuses people who feel like, well, we can just check your chromosomes and we'll know your gender, or we can just look at a baby's genitalia and know their gender. But you'll see in a moment why that is absolutely not true, and why the clarity of words that we use is really, really important. So gender is how a person feels internally. It is not sex. Sex is what you are assigned at birth. Some level of femaleness or maleness. Some people appear clearly male. Some people, babies, appear clearly female. But there are plenty of people who are born and it's not clear, or there's a mix of genitalia, some that look more female, some that look more male. So gender identity is completely different from sex assigned at birth. It is how we feel. And we're going to talk quite a bit about gender identity and what that even means. But I just want to throw that out right from the beginning, that gender is not sex. Sex is what you're assigned at birth. Gender is how you perceive yourself to be. And there is a spectrum of femaleness in how I might feel about myself, or maleness in how I might feel about myself. So first step is clarity of our words. And this is what I really hope we can teach to medical students. Sex is what you are assigned at birth. Gender is your personal sense of yourself. And I did not make up this genderbread person. I love this, though. You can find it on, if you Google this, you'll find the person who created it. It's not me. But I think it's a wonderful opportunity for us to explore, what are all of these terms and what does this mean? So gender identity is how we feel about ourselves. Gender expression, though, is even different. Gender expression is what we show to the outside world. Our sex assigned at birth is one thing, and our attraction to people is a whole other thing. So sometimes all of these words get mixed up together like they're one thing, but they're so clearly different. The sex we were assigned at birth, our identity about how much maleness or femaleness do we feel, that's our gender identity. Our expression, what do we put out there to the world, and our attraction, who are we attracted to, either romantically or sexually. These are all really discrete ideas, and we're going to dig into them a little bit more in a minute, but that's important for us to know. These are 4 discrete ideas. I think medical students really need to learn this so that they have a context to understand what we're talking about. Okay. So the concept of identity and expression and sex and attraction applies to all of us, right? We all have various kinds of identities, how we see ourselves in general, not just gender identities. We all have decisions every day when we leave the house or put on what we choose to put on after we take off our pajamas. We all have a sense of expression. What are we telling the world about ourselves? We were all assigned some sex at birth, male, female, or intersex, and we all have some amount of attraction to other people, maybe more feminine type people, maybe more masculine type people, maybe both. So this is not like, oh, there are people who have separate identities. We all have identities. We all have expression. So for example, I have multiple identities like you all do. I'm a mom, I'm a wife, I'm a physician, I'm a woman, I identify as a woman, I'm a dog owner, I read, I feel like I have a creative sense of myself. And how do I express that? I dress in a more female way, but not overly feminine. So some people dress in a more feminine way than I do. I tend to be, in my expression, kind of casual. So I don't have a fancy purse that matches my shoes. You can tell by the color of my hair that I don't dye anymore, that I'm somewhat accepting of aging. I tend to express myself in a friendly way, right? So we all have identities, we all have expressions. And I think this underlying concept is extremely important to teach to learners because it makes it less likely that they will put someone who has a particular gender identity in a box of like, well, there's regular people and then there's that unusual thing. It's not that at all. We all have identities that we all choose our expression. Some people choose that, we all choose it really around gender and how we express ourselves. So what I'm trying to say is that we want to normalize this concept of having an identity and choosing how you express yourself. So I request that you actually engage in this conversation, all of us together. So put in the chat something about how you would describe your own identity. How do you see yourself? So it doesn't have to do with gender. It can if you want, but it certainly doesn't have to. But as I describe my own identity as a mom, a physician, a dog owner, etc. So at least one thing about how you describe your identity. And then how would you describe your expression? How would you describe how you present yourself to the outside world? As I mentioned, so I chose not to dye my hair anymore. That was an intentional expression to the outside world, a choice that I made. So we all do this all the time. So let's share. What are some ways that you see your own identity and some ways that you express that? Anybody willing to share? It helps the group. If you're willing, it helps the group to see that how other people see themselves. So what do you think? A cis female, but rarely wear dresses. Right. So that, thank you for sharing that. It's an important concept that we have these sometimes buckets that we think we put people in, that all females would be a certain way and all males would be a different way. But you are so right that we can be a cis female and have some spectrum of femininity, classic femininity in the way that we dress. So an identity cat owner and daughter of an elderly mom, 94 years old, good for your mom, attracted to men. Another expression, casual, funky jewelry wear, curly gray hair sister, all natural. So look at the expression that tells people some about who you are. Mom, wife, nurse, cat and dog lover, fantastic. Glasses wearer, exactly. So even that is a decision, right? I'm wearing glasses, I could wear contacts. That would be a different decision. Identity vegan, beautiful. So thank you so much. You can start to get a sense of, we all have identities of various kinds. Some are gender, some are other things. And we all have choices about how we express. And I really think that doing a little exercise like this with medical students and residents is important so that they can see that choosing to express your own identity, to know your identity and choosing how you want to express it to the world is a human thing. It is not an only gender thing. It is a human thing. And that helps with empathy, that helps with not putting people in a box, that helps with understanding how painful it would be to have others minimize your identity, right? So if I perceive myself to be a loving mom, a good mom, a listening mom, and someone comes to me and says, no, I perceive you to be a terrible, selfish mom, that would really wound me because my identity that I see is being disrespected and unseen by another person. So this concept is easier to understand when we separate it for a moment from gender expression and then bring in the idea of gender expression of like, look, here's an example of people owning their own identity and choosing their expression. And it's just the same as our own identity that we own and the expression that we choose. So thank you guys so much for sharing. That really helped. Okay. So this idea and part of what gender affirming care means is respecting someone's chosen identity because we really want to be seen as who we are. And so if who I am is a trans male or a trans female, then being seen and respected for who I am is crucially important. And that's why things like pronouns, which we'll talk about in a minute, are not just like, oh yeah, your pronouns. They are crucially important to people. And so disrespecting someone's chosen pronouns is really saying, I do not accept your identity, or I don't respect your identity enough to honor it the way you want me to honor it. So it is, people sometimes feel about pronouns like, oh, whatever, choose your pronouns, yeah, blah, blah. But it is fundamental to someone's identity, and therefore it is really crucial that we respect that when we're taking care of patients and families and loved ones even, or ourselves. Okay. So just to make sure we have a couple terms that we agree upon, we talked about sex, which is what you were assigned at birth, male, female, or intersex. And we'll talk in a minute a little bit about intersex and what is that. But there really are three ways you can be assigned at birth, male, female, and intersex. That's sex. Gender is this social construct. Be male, how do I see myself? I could see myself as a male. I could see myself as a female. I could see myself as non-binary, meaning not fully male and not fully female. So I don't, in that case, if I identify as non-binary, I don't fully see myself in the male bucket or in the female bucket. Other terms that people might use about themselves are gender fluid or gender non-conforming, which is similar, but not exactly the same as non-binary. People often use those terms to make it clear that they haven't chosen one bucket at all. So it could be fluid. Sometimes they might feel more male, sometimes they might feel more female, and that might mean, over time that morphs. So that might even mean yesterday I felt like expressing my more male side, and today I'm feeling more female. So gender fluid or gender non-conforming is specifically saying I'm not choosing a box. Right? Binary is the box, male or female. I'm not choosing that box. And I think this is an important concept because people get this. A person could be transgender binary. So they could have been assigned at birth as a female, transition to male, feel fully male. They would not say that they are non-binary. They would say that they are male. They're a man. Other people, though, might not feel comfortable with box A or box B and might feel somewhere in the continuum of non-binary, gender fluid, gender non-conforming, sometimes the term gender queer people use. So in terms of gender, cisgender means whatever you were assigned at birth is also the identity that you feel. So if you were assigned as a female at birth and you feel your gender identity is female, you are cisgender or cis. If the gender you were assigned at birth does not fully match your identity, how you feel, then that is transgender or trans. So if someone was assigned at birth as a female, now feel somewhere in the continuum of not all the way female to all the way male, somewhere in that continuum, that person would likely consider themselves to be transgender or trans. Is that clear? You guys will stop me. If someone says in the chat that it's not clear, someone let me know. Okay. So People who do not fit, do not feel totally in the all the way female, all the way male category, whether or not they were born and assigned male or female at birth. Those people, as I said, can refer to themselves as non-binary, gender non-conforming, gender fluid, gender queer, and that may change over time. A trans man or trans masculine person assigned female at birth, but identifies somewhere on the continuum of man, male, or masculine. Trans woman or trans feminine was assigned male sex at birth, but identifies somewhere in the continuum of female or feminine or as a woman. But these are not mutually exclusive. So a person can absolutely perceive their identity to be different than what their assigned sex at birth was. So they might consider themselves trans. They might be trans gender non-conforming, or they might be trans man or trans woman. So these are not mutually exclusive terms. You're not either trans or gender non-conforming. You could be trans, male or female, gender fluid, gender non-conforming, non-binary. All of these are possible, or binary. Someone may have been assigned at birth as one sex. Their gender identity might be the opposite sex, so they may have been assigned female. Now they feel fully male. That person is not non-binary. They're trans, but they're a trans man now or a trans woman. And even though the discussion of terms may seem, I don't know, small, I think it's important because these terms get thrown around societally. And I think if we don't understand what they actually mean, we have a harder time really having empathy for people who are finding their place on this continuum. And as clinicians, we can accidentally be disrespectful and wounding of our patients, which we don't want to do. So having just sort of a basic understanding of what these terms mean, and then with an openness though, because first of all, terms change. And second of all, not everybody in the community will perceive these terms in exactly the same way. So we want to have some humility around, this is what I think I know right now, but to be open as the community educates us or changes, or an individual person might feel a little bit differently about what your gender fluid, for example, means to them. So we want to have some basic knowledge and then approach it with humility and be open to having conversations and to continue to learn from whatever person we are talking with. Okay, so we talked before about gender identity, but I want to talk for a moment about the specifics of gender expression. So one's identity, if I feel female, is not the same as my gender expression. So I make a choice about how I present myself to the world, what clothes I choose, what hair I choose, what behaviors I choose that may be sort of stereotypically more feminine or masculine, what I do with my voice. All of those things are expression, and they don't tell you what somebody's gender identity is. So we should not assume that by looking at somebody, we know what somebody's gender identity is. So for example, someone could have been assigned male at birth, have a gender identity of male, feel male. So they're cisgender, they're not trans, but they might choose to wear dresses because they enjoy that. That person has a gender expression that is maybe more stereotypically female, in that in the US society, it's generally women that wear dresses, but they're not trans because their gender identity is matched to their sex assigned at birth. That person is cisgender male who might choose to wear dresses. So gender identity is different than sex assigned at birth, is different than gender expression. And the underlying theme here that I think is crucial for all of us, and it really is the fundamental idea, is that we should not assume. And that is the behavior that is tough, but that is important for us to develop, is to not look at a person and assume, I know what your gender is, I know what your gender identity is, because I'm judging by the things that you are wearing and what you've done with your hair and what you've done with your behaviors and your voice. We don't know, and we should not assume. Okay. Pronouns, as we mentioned before, are chosen by the person. They are not related to any particular event. So it's not like, oh, you had top surgery, so now your pronouns are different. Pronouns are not for anybody to assign to a person. They are for the person to assign to themselves. So a trans person may change their pronouns from if they were assigned female at birth and now feel fully male, they may use he, him pronouns, or they may not. It's not, there's no rule, and there's not for us to say, well, you look male, so your pronouns must be he, him, because that could be wrong. And here again, the idea is don't assume. So if you look at a person and they appear to you to be stereotypically masculine or male, do not assume that their pronouns are he, him, because we don't know that. And when we misgender someone by using pronouns that are not their chosen pronouns, we wound them based on all the stuff we talked about before about identity and not having your identity being affirmed. So using someone's pronouns that they have chosen for themselves is really crucially important. And how do we know what someone's pronouns are? We ask, right? It's okay to ask. What pronouns would you like me to use? What are your chosen pronouns? And then to respect that person and actually use those. So pronouns, chosen pronouns are so important, and we should not assume. And one of the things we're going to talk about in a minute that's hard is I'm not just saying we shouldn't assume in a person that we perceive to be transgender. We shouldn't assume for anybody because we have no idea what anybody's gender identity is, and we have no idea what their pronouns are. So the behavior and the way we speak ideally would start to morph away from gendered language that we use all the time. Like, oh, could you tap that woman on the shoulder and let her know that her son is here? Right? There's a lot of gender in that statement. We don't know any of those things. We don't know that that person identifies as a son. We don't know that that person's a woman. So just start to think about this idea of we might ideally want to change the way we use gendered language, which we do all the time. And I'm in no way saying that I'm perfect. I do it all the time, but I'm now more aware of it and trying to make a change. So just to say for clarity, because this also comes up as a question, a trans man is a man. So we don't have, if we know that trans man identifies as a man, we don't have to say trans man again, that person is a man. That person, that man, may have a uterus, which we're going to talk about in a minute. That's why it's so important that we not make assumptions, because we need to know how to give good healthcare to this man, but this man may have parts that we might be assuming they do not have. And the same in reverse. A trans woman is a woman. That woman, though, could have a prostate that maybe needs to have cancer screening. So a trans man is a man, a trans woman is a woman, but we have to have understanding of the bigger picture so we make sure that we're giving proper and appropriate and thoughtful healthcare to this person. And a trans person who is gender nonconforming does not identify solely as a man or solely as a woman. They may identify as masculine, more masculine than feminine, or more feminine than masculine. That might change over time, but that is their identity. Now, this is a thing that has happened in the community that I think breeds some misunderstanding. So the LGBTQIA community is a community. People sometimes assume then that all trans people are gay, but that's not true. Trans people can be gay, they can be straight, they can be pansexual, they can be asexual, just like anybody else. So gender identity and sexual orientation are not the same thing. Not the same thing. Gender identity, remember, is our internal sense of who we are. Do we feel more male, more female, or a mix? But our sexual orientation is who are we sexually or romantically attracted to, which is a completely different thing. So don't assume that every trans person perceives themselves to be gay. That absolutely, it could be true, but it may not be true, and it's not something for us to assume. So this is, again, don't assume. And also don't assume that someone who appears to you as androgynous or gender nonconforming, don't assume that they identify as trans. They may, but they may not. So the overarching ideas here are, let's assume less and let's try to use less gendered language. Those are the things we're going to pull out by the end that we're going to try to change in terms of our behavior. Don't assume, and let's try to use less gendered language.
Delia,
So, yes.
I have a question from the chat on one of the terms from the last slide.
Okay.
And the question is, what is pansexual?
So pansexual, it refers to people who are open to having sexual relations with anyone, regardless of their gender, regardless of their parts. So interestingly, I think even the term bisexual in some parts of the trans community may feel restrictive and excluding, because the way we have standardly used bisexual is men and women, but there are people who are intersex, there are people who are trans non-conforming, who may feel more masculine or more feminine, but bisexual implies this bucket or that bucket. And so pansexual is probably the evolving term that is more saying, I don't choose just one gender to be sexually attracted to or romantically attracted to. I am open to people regardless of what their gender identity or their parts are.
Thank you.
Sure. Yeah, you guys, I struggle with that too, you guys. I know we have so much gendered language. Interestingly, we use you guys for women, a group of women sometimes too. So I don't know what the answer is, but I think having the first step is having awareness of our gendered language. I think that if we used you guys and there was in that group someone who was a trans woman, that woman might, everyone's different, but might take offense at that. They might perceive it like we were minimizing their femininity. I'm not, who knows, but it's just something to be aware of. That is a way that using that term, you guys, which I also struggle with, might inadvertently offend somebody or make them feel unseen or uncared for, which of course we don't want to do. Okay. So let's talk about intersex for a minute. The idea of intersex, and here's a way I want kind of you to expand your view of this. Many of us have this idea that the body is either male or female. Whether or not you choose your gender identity, your body is either male or female. But that is not true, actually. It's really not true. And the way I was taught in medical school about intersex babies, I'm hoping that we can change that now and teach medical students in a different way. But the way I was taught is that something went wrong. Something went wrong. This baby is born with genitalia that are partially female and partially male. Oh dear, we have to fix it. And I would just encourage you to open your mind that there's another way to look at that there are people in the intersex community who feel like they are not broken, that this is another way to be, that babies can be born with male genitalia, female genitalia, or intersex genitalia, meaning some components of both, and that doesn't need to be seen as broken or bad or something that has to be fixed, that can be an identity. And there are people who identify as intersex. That is their identity. So with that perspective, that intersex can be an identity, perfectly valid identity like male or female, I don't have an answer here, but boy, it should give us some pause about what sometimes happens, which is that parents and doctors will often choose the sex of a baby who is intersex. So based on what they see phenotypically, they will choose sometimes this, we're going to make this baby look female. And that baby, for example, might have undescended testes that at some point could have produced male hormones. They may be removed and the genitalia surgically altered to appear female. That to the parents and to the doctors might feel like, oh, good, we fixed a problem. But when that person grows up, what if they feel male and their potentially functioning testes were removed at birth by their parents and the doctors? and that's irreversible. So there are adults who are extraordinarily angry at what happened to them as babies because somebody chose their sex when maybe that's not the sex that is going to match with their gender. So I don't have any answers here, but I think just sharing this perspective with medical students that intersex is not broken and isn't something that necessarily has to be fixed, but could be a perfectly valid other identity is just something that we should discuss. And there are now some hospitals have a gender committee to bring this to help decide what to do. And I have no answers, but I think at least we should move back from that baby is broken and let's fix it, because that's what I was taught. And that has caused distress for people who are intersex. And it is not that uncommon. It's not extraordinarily rare. 1 in 2,000 is not that uncommon. So some people think, well, if they're intersex, then they're trans, right? No, not necessarily at all. You can be both intersex and trans, but they are completely different things, unrelated. You could, in the example I gave, if you remove someone's testes and change their genitalia to look female, and that person grows up feeling male, in a sense, we have created someone who's trans because we assigned them female at birth, took away their male hormones, and they feel male. So now their identity doesn't match what they were assigned at birth. So they are different concepts, but they can be related in that way, but they are completely different concepts. It's not like trans people are intersex necessarily at all, or intersex are trans people necessarily. Certainly there could be an intersex person who had surgery and then identifies with that gender when they grow up. That's a cis person who was intersex who had surgery and assigned a sex at birth. Any questions about that? I know that can be sort of a confusing topic. Okay, so then I would really encourage you to bring this up as part of medical education, just as a concept. There's no answers, but I think this idea that intersex itself can be an identity and that there's risk in choosing somebody's biologic sex for them when they were not born with that, and just leave it as a place that we wrestle. Leave it. You can talk about it, for example, in a discussion on ethics. What should we do here? Who has the autonomy? The parent on behalf of the child, or does the child have autonomy and we shouldn't take that autonomy away with a permanent surgical intervention? I think an ethics discussion is a great place to bring up a topic like this. And just in the discussion, it gives the message that I think is important for medical students, which is that intersex people are not broken and necessarily need to be fixed, but this is an experience. This is a baby born in this way. And how do we match that with society and what will we do about it? But it isn't like this is a broken baby that we have to fix, which is how I was taught. Okay. Any comments or questions, things that you think are important to bring up before I move on a little bit? I'm going to read. How about y'all? I love that. Actually, we were talking about you guys versus y'all. I did ask somebody who has the experience of being trans about y'all, and they said, yeah, that's good. That's a good one. They thought that was a non-gendered, all of you people kind of way to communicate. Yeah, so somebody validated that a friend who's trans said that you guys is hurtful. And it is really hard, but I think it's so important. It's such a great example of how we don't mean to be hurtful. We don't mean to exclude someone or invalidate their identity. And that's why it's so important to have this conversation, I think, is that it just makes us think about our words in a way that we might not otherwise. We can be out there hurting people all over the place with no mean intention in our heart at all, but it doesn't mean that we don't hurt them, even though we don't mean to. And that's why it's so important. And then somebody recommended the biography Becoming Nicole about a transgender woman. It really gave me insight. Thank you for sharing that. I haven't read that, but I will take a look at that. Okay. And the elephant in the room is that sadly, some people do mean to be hurtful. You're right. So, okay, let's just say that there is horrific violence and cruelness that comes towards the trans community, for sure, which is awful and terrible, and we need to fight against that. And also, though, and the reason I think it's important for us to have this conversation is that just because I might not feel that way about the trans community doesn't mean I might not also inadvertently be hurting somebody. And so I think we can, if we're not careful, feel like, oh, well, I'm accepting of everybody, so I must not be hurting anybody, when in fact, just the way we're used to talking can be hurting people, and we may have no idea. So, of course, people should not be cruel, but also even those of us who don't feel in any way negatively towards the trans community also need to self-reflect and look at our language, because we might also be hurting people 100% without meaning to. And me too, still, I just, this is an evolution, I think, for all of us. Okay, so truth number 2 is that providing gender-affirming care is crucial for all physicians. So this is not a niche idea, like, oh, well, I don't work with transgender people, so I don't have to know about this. Of course you do. So people who are in the transgender community may have a specific medical center that they go to if they live in a big city. But first of all, lots of people don't live in a big city. And everybody ends up at the dermatologist and the gastroenterologist for your colonoscopy and the emergency room if something happens to you. So there are no physicians who might not encounter someone who is trans or in the trans community or struggling with their gender identity. All of us will. And so all of us need to know about how to be thoughtful and sensitive and appropriate. Everybody. This is for everybody. And I think that is an important concept. It's part of why I'm so glad you guys are here, because I really wanted this not to be for people who are interested in the trans community, because this should be for every medical student. Every medical student needs to have awareness, needs to self-reflect, needs to think about their language, needs to think about what their medical record looks like, needs to have strategies when they have a patient who is trans and they want to, the person perhaps is presenting as female, as a trans woman, but the doctor wants to know, well, is there a prostate? Do I need to do a PSA? And I don't know how to talk about that. So all of us need to have these skills. All of us, all of us, all of us. And thank you all in advance for teaching these things to your students. Okay, so interactions with the medical system are not great. Not great. So a significant number of the US population is trans. In this study in 2014, it was 1%, but that's the number of people who said it. There probably even then were people who did not say it, we didn't feel comfortable sharing. And it is certainly possible that that number is higher now. That's my guess. But even in that group, 25%, a quarter of people who answered these surveys said that they delay healthcare because they're afraid of being discriminated against. So they know they should go to the doctor and they don't go because they're afraid the doctor or the nurses or the staff will discriminate against them. How heartbreaking is that? Right? So we need to not only learn ourselves how to be non-discriminatory, but then we need to give the message, you can come here. This is a safe place for you to come, because imagine if a quarter of your patients delayed their healthcare because they were afraid of you. They were afraid of what would happen to them in your office. 19% of people in this survey said they had been denied healthcare because they were trans. And 28% experienced verbal harassment when they were interacting with the medical system. So going back to the elephant in the room that somebody said before, that some people really are negative and unkind on purpose. Look at that. 28% of this population felt verbally harassed when they went to seek medical care. So no wonder people don't seek medical care. So we have to fix this. This is totally unacceptable. This is a million zillion % unacceptable. We have to fix this. And the way we fix it is by fixing ourselves, by educating the doctors of the future to make it clear to all of their patients, including their trans patients, that this is a safe place for them to come, which means they have to learn how to train their staff, because the doctor may interact in one way, but if the nurse or the person at the front desk interacts in a different way that's negative and insulting, then that person may not come back, that patient may not come back. So the doctor needs to deal with their own stuff, and then they have to learn to train their staff and give feedback if things don't go as they should. So once upon a time, being transgender was considered a mental health condition. It is not, it is not, it is not, it is not. The AMA and the American Psychological Association endorse gender-affirming care. It is not a mental health condition. But the DSM-5 definition that you will see is gender dysphoria. But this is really important to know, and this is crucially important to teach medical students. Gender dysphoria is not because being trans is bad. It is the dysphoria of someone who has this experience with their struggling with their gender identity, and they live in this society where they don't feel accepted. So it focuses on the distress, not on the fact that there is an identity challenge. And having gender affirming interventions can reduce gender dysphoria, right? So if a person has gender dysphoria and they want to transition medically or surgically, and they do that, that dysphoria often goes away. So that is really important to teach to medical students. It's not being trans that is something abnormal. It is the struggling with what do I do? Who am I? How do I live in this society? That is what's in the DSM-5. Now, that said, there are tons of mental health issues in the trans community, which is basically because of the challenges of living in our society that is not always accepting of who they are. These statistics from UCLA, I just think are heartbreaking. 81% of trans people in the US have thought about suicide. 81% of people have thought about suicide. That's a crisis. And 42% of trans adults in the US have attempted suicide. So this is a mental health crisis, not because being trans is bad, but because living in a society where there's gendered language all over the place, where people don't respect you for who you are, people want to hurt you and think you're bad or broken. That is what causes so much distress that people are so depressed that they consider or attempt suicide. So teach this to medical students too, right? This is why you need to learn this stuff, not because, oh, it's nice to be good to your patients, but because this could save somebody's life. A person who's trans finding a doctor who completely accepts them, who respects who they are, who uses their appropriate pronouns, who trains their staff so that the whole office feels supportive, that could literally save somebody's life. That's how important it is. Okay, let's talk about names for a minute. Names are really important for all of us. They are especially important for people who have transitioned because their birth name or dead name, as it's sometimes referred to, refers to a person that is not them, in a trans person who has transitioned in some way. And so using that name, and this may happen in their family all the time, that people don't respect their new chosen name and use their dead name instead. That can be extraordinarily emotionally painful. And so we want to make sure that we don't do that. And this can come up, and it's an issue for us because that may be the name on their chart. That may be the name on their insurance card or on their driver's license. And so we want to have some thoughtfulness about using the name that may in fact be on their chart. So in the ideal world, and this has changed in a lot of places now, not everywhere yet, some hospital records will say legal name and chosen name or preferred name, and we must always use their preferred name. Just recognize that using their birth name is an injury, an emotional injury to that person. So if we do it, we should apologize, of course, but just I think it's important for students to understand it's not just like, oh yeah, sorry. It's not good. It's hurtful. And we really should try to use the name that somebody has chosen for themselves. And ideally, if your medical record allows it, you should make sure there's a place for chosen name. If your medical record doesn't allow it, have a sticker or a place in the chart where you can see it so that you don't, if possible, inadvertently call somebody by their dead name or their birth name.
We have a really good comment about that, Delia.
Yes, tell me.
Someone said it to just the hosts and the panelists. They said hospital policies also discriminate. So I'll pause here and say I'm interested if other people see this too. Hospital policies also discriminate by refusing to make gender and name changes to the EHR, even though the local courts have processed and approved it, making it impossible to use health insurance. Parentheses, names gender don't match between insurance and the EHR. We need to address discrimination at all levels of healthcare administration.
1000%. Thank you so much for sharing that comment. Yes, it is really a problem. And we don't have a solution today, any of us, but it is really a problem. And the first step is to acknowledge that it's really a problem. So we can address it in a couple different ways. We can address it from the policy perspective. We can talk to hospital administration. We can talk to insurance companies, but also we can be an ally with the patient who is finding themselves in this really difficult situation where they may have to speak their dead name in order to get health insurance, in order to find their records. And that's very painful. So at least kind of apologizing for the system. I'm so sorry that this is happening this way. You may end up getting some communication from the hospital that has that name. I wish it were different. We're working to change it. I apologize for that, but I want you to know that I have put your preferred pronouns, I've put your preferred gender, I've put your preferred name in our records where I can, and as much as possible, we will respect that. So on the one hand, yes, it is horrendous and it has to be fixed. On the other hand, we should at least do what little bit we can, which is be an ally with the patient and saying, I know this is a mess, and I see that it's hurtful, and I want to kind of warn you about that this might happen, but here I'm on your side, and here are the things that I can do to make it better, and I will do those things because I respect you and I care about you. Great, great, great point. Thank you so much.
Thank you.
Okay, so what do we do if we misgender or misname somebody? Just apologize. So you definitely should apologize, but don't make a big fuss. Sometimes people can make a tough situation even worse by over apologizing. Oh my gosh, I'm so sorry. I so support you. Don't do that. That's embarrassing to the other person, and it kind of makes it about you, like you're feeling bad, and now they're supposed to say, oh, it's not, it's okay, it's okay. Don't do that. Just apologize because you're acknowledging I messed up. I'm so sorry I used the wrong name. I'm sorry that I misgendered you, and then move on. That's really important. And this is another skill that we can teach to medical learners. Okay, so I think that we can, because it's hard to put all the pieces together, let's think of the 5 A's of providing gender-affirming care. And this is something that we can teach to medical students. So we should avoid assumptions. I look at you and I decide in my head if you're male or female and what I think your pronouns are. We should avoid assumptions. We should avoid gendered language. And that includes, excuse me, sir, could you sit over there? You don't know if that's a sir, and that may be very offensive to that person. You can just say, excuse me, blue shirt with the big earrings, excuse me, can you sit over there? Ask about people's pronouns and preferred name. How can you know unless you ask? And it's respectful to ask. What name would you like me to use? What pronouns would you like me to use? What are your preferred pronouns? Apologize, but just very briefly without a big drama if you misgender or misname someone. And like we were just talking about, add new information into the medical record wherever you can. In the hospital, in your office. Ideally, it's in the medical record setup, but if not, find another way to do it. You can add sticky notes. There's other things that you can do. Add the crucial information of the person's preferred gender, preferred name, and preferred pronouns. And then advocate for your patients and be brave. You know, if somebody says something that's disrespectful, you got to say something. You got to say something. We have to be advocates in this community. So let's talk a little bit about each of those. Avoiding gender assumptions and gendered language. Things like, hello, Mr. Lee. I don't know that that person identifies as a Mr. How can I help you, ma'am? Right? We do it all the time, all the time, all the time. And so my homework for you is to just start to notice how often you use gendered language without thinking about it. And often we don't have to. So instead of saying that man, we could say that person with the short dark hair. Let's see if we can get away from that man, because if that person identifies as female and they hear you say that man, you've wounded them without intending to, you've wounded them. And then the other assumption that we in the medical field have to look out for is don't assume that the name on their chart is their preferred name. So ideally, we get set up right from the beginning, patients that are seen in the office, what's your preferred name? You might say, what's your legal name? What's your preferred name? And always use the preferred name. So think about the risk to a person who's sitting in the waiting room presenting as male, whose legal name might be Sarah, and you come and say Sarah Smith, and that male looking person has to stand up, you may now put them at risk because you don't know what the people in the waiting room think, and you don't know if any of them have a tendency to be violent or have negative and unsupportive thoughts about people in the trans community. So just be really thoughtful about the risk of using somebody's birth name if it's not their preferred name. So I won't make you write this because we're running a little bit out of time, but just think for yourself, have you ever made an assumption about a patient's gender? And I have, of course, a gazillion times. I'm trying to be more thoughtful about it, but I'll give you one example. I had a patient who was a woman. She presented to our office. I was in family medicine at the time. And our staff said, when was your last menstrual period? And she gave a date. And so I see that date on the chart when I opened it. It was a paper chart at the time I opened it. And then I do a physical exam on this woman and she has a penis. And of course, I was surprised, of course, because there was a last menstrual period on the chart. And so I asked her, so tell me about the last menstrual period. And she said, I didn't know what to say. I was unprepared for that question. I didn't know what to say. So just think if my staff, instead of saying, when was your last menstrual period, said, do you have periods? And then she could have said no, and then that wouldn't have been on the chart and she wouldn't have been in that uncomfortable situation, just as an example. Okay, so ask, what would you like to be called? What pronouns do you use? Apologize, like we said, I'm sorry I used the wrong name, I'm sorry I misgendered you, but just make sure you're not making it about you. We talked about adding things to the medical record, name, gender identity, and we talked about mentioning if their legal name is different than their preferred name, that they may get some paperwork and that you apologize sort of on behalf of the system that is still not working properly around this issue, you're sorry. And one thing I think can be very helpful is you can offer to give the person their medical record number. So if they have to call and say, could you send me a copy of my CT scan? They don't have to use their dead name. If you have their medical record number, they can just call up and say, my medical record number is this, can you send me my CT? Otherwise, they're going to have to use their legal name, which might be very painful for them. So that's a small tip that we can use to help be supportive and be a better ally. And then advocate. If somebody that you work with says something unkind or disrespectful, you got to speak up. You got to say, hey, I heard you use that term and I don't like that. I don't want you referring to our patients that way. Please speak respectfully about all our patients, and maybe even escalate it and tell the staff, hey, you know what, the leader, there are some staff making inappropriate comments about trans patients. Can we do some kind of in-service? Can we all talk about this and learn something better? And then you would perhaps be shocked at the words that people use. Please don't ever do this. And please teach your medical students never to do this. Don't say things like, wow, you look like a real woman. You're so pretty. Or it's so great that you can pass as a man. That may sound like a compliment, but for many trans people, that would be an insult. And that would be a very disrespectful thing to say. Also, don't out people. You're trans, right? That's not for us to ask. And if somebody's name doesn't match how you think they should look, don't say, you don't look like a Susan, you don't look like a Joe. And 100%, you would never ask other people in your life about what their genitals look like. So it's completely inappropriate to say, have you had bottom surgery? Unless you're the physician and you're planning to take care of that part of the body, then of course it's fine to ask about what genitals they have. But other than that, that is not just a casual conversation or a curiosity kind of question. So I was taught to say, do you have sex with men, women, or both? But that turns out not to be a helpful question, because a man could have a vagina, a woman could have a penis. What you really want to know is, do you have sex with people with penises, vaginas, or both? So I would recommend teaching medical students to ask this question in this way. And you can ask, is pregnancy a possibility for you? Don't assume, because there could be a male-looking person, even somebody with a beard, who still has functioning female internal organs, and pregnancy could be a possibility. So don't assume that you're looking at a male person, you're going to prescribe a medication that would be unsafe if they were pregnant. Don't not ask, because you don't know. Maybe pregnancy is a possibility for that person, even though they're presenting their gender expression is male. So is pregnancy a possibility for you? Do you have periods, even in people who appear male? And then you can ask, can we talk about cancer screening? And then if it's appropriate, at the kind of doctor that you are, do you have a prostate, cervix, uterus, or breast tissue, regardless of what the person appears like? Because they may look to you like a woman, they may be a woman, a trans woman, but they may have a prostate that still needs to be screened for cancer. In the hospital, I've seen this and it's so heartbreaking. Please advocate for your patients who want to continue their hormones if they can, who maybe want to use chest binders or breast forms, packers, which are can be just a sock, but often is a penis shape to give a bulge in the underwear, and advocate for them if needed. Their hospitalists may feel like, oh, you don't need that, you're in the hospital. But if that's part of who they are, part of their identity, it might be really important to them. And the only way we know is to ask. Make sure not only that you use their preferred name and pronouns, but that you tell everybody on the team. When I've taken care of transgender people in the hospital, half the people use their preferred name and pronouns, and half the people don't. So have a team meeting to get everybody together to talk about it, to make sure that you are not continually misnaming or misgendering this person who is sick and trying to get better. Same for end of life. Even on hospice, if they want to continue their hormones because that is their identity, they want to keep the beard that they have, advocate for hospice to cover that. If they want to keep using packers and breast forms, advocate for that because it's part of who they are. And this one, I heard a story that just broke my heart. This story was about somebody, a family who after death changed back the gender of the person for their funeral. So that is something worth talking to people about if you're caring for them at the end of life. Who is it that will be getting them ready for a funeral if they're going to have one, and make sure that they are respectful of their chosen gender? Imagine that. Okay, so we've been talking this whole time about how we have to teach medical students to do this properly. We have to teach them the difference between sex and gender. We have to explain the importance of non-gendered language. We have to model this when we're taking care of patients. And we've got to, if God forbid you hear somebody being disrespectful to a transgender patient, we have to advocate out loud and show medical students how to do that. We have to make sure to screen for cancer, even if the organ is different than how the person is expressing themselves. And we really got to check for depression and suicidality because it's such a high risk. And teach the students the 5 A's. Avoid assumptions, ask about pronouns and name, apologize if you mess up, add new stuff to the medical record, and advocate for your patients. And then how do we model being an effective ally? We normalize honoring our own identity, gender and otherwise, which is why I think it's such a great exercise the way we started that you can do with medical students. Let's just talk about identity and how important it is. We can model the kind of communication we want medical students to have. We can educate ourselves about gender issues. It's not the patient's responsibility to teach us. We should be teaching ourselves, and we should teach people to make sure that they're not outing their patients without their permission. Here are some resources. McGraw-Hill actually has a book that is a great book that I actually used myself to help prepare this, called Transgender and Gender Diverse Healthcare, the Fenway Guide. You see that? It's a really great book. So if this is a topic that interests you, you might check that out. And thank you so much for your attention. I really appreciate it.
Thank you so much, Dr. Chiaramonte. That was absolutely incredible. I learned a lot. I know we had great comments and questions in the chat. I know we're a little bit over time, so I will just say thank you to anyone who cannot continue to join us. Thank you so much for your engagement, your thoughtfulness, and your willingness to engage with a topic that can be hard to talk about, but is so centrally important to the lives of our patients and our students that we're teaching to care for those patients. We do, if you can stick around, we'll have Dr. Chiaramonte answer some questions. And I'll also show you, before we dive into those questions, I want to show you how you can get your hands on the Fenway Guide, because if you subscribe to Access Medicine, which many hospitals and colleges of medicine do, you actually have access to the Fenway Guide, that transgender and gender diverse healthcare book. So let me share my screen briefly. All right, so you should be able to see Access Medicine. You may notice the site got a new look last week or the week before. Can you see my screen? Yeah? Okay.
Yes.
Great. So actually just on the homepage right here, we have this book rotator that goes through the most popular titles on the site. And Transgender and Gender Diverse Healthcare, the Fenway Guide, is one of those titles, a really great thing to see. So if you subscribe to Access Medicine, you have access to the entirety of this title. And so do you, your students. So it's really easy to integrate it into your education. You have access to this really high quality resource that informed Dr. Chiaramonte's talk today. If you're not sure if you have access, check with your library. Otherwise, I'll put the email for my department in the chat and you can check with us too, just to see if you have access. The last thing I want to point out about resources for engaging with your communities about, especially your student communities, about transgender and gender diverse healthcare is we have created, if you go to support, training and support, we actually have a content map that our subject matter experts created that identifies some key titles that discuss diversity in medicine. And these will be resources all on Access Medicine. So let me share my screen one more time. One thing about this resource, it does touch on all sorts of, we talked at the beginning of the session today. Dr. Chiaramonte led us through that really good, the different components that make up identity. So of course, gender, sex, orientation, those are, of course, part of identity and diversity. And this subject guide goes through some resources tied to sexual and gender minority patients, as well as other aspects of or other socially, why can't I think of the word? Other minorities, other groups that need some kind of cultural sensitivity or competencies that you can help to develop in their care. So those are just two resources I wanted to pull out there. We do have time for some questions if people can stick around. So I know we got two from the chat that I want to bring to Dr. Chiaramonte. The first one, this question was, when teaching students how to clinically present a patient to a faculty member, should the opening statements such as ABC is a 50-year-old male, present with a chief concern of, should that only include sex? They say the lead at our school feels that gender should be mentioned during the social history, not the opening line of the presentation. What do you think is kind of an appropriate stance?
That's a great question. I think that that whole habit that we have of presenting sex, quote, in the presentation is no longer as clear, because a trans woman is a woman, but she has a penis, potentially. She may not, but she may. So if you say I have a 55-year-old woman, that doesn't necessarily give you the medical information that you're looking for, because a person who hears that might think that person, that the patient may have ovaries, is not thinking about prostate cancer screening. So I actually think we need to rethink this whole concept, because it's no longer as helpful, that statement. A 55-year-old woman, what does that mean? So I think personally, the assumption, I'm not saying it should be the assumption, but the assumption when you say that is that that is a cisgender woman. And that if it is not a cisgender woman, from a medical perspective, probably it should be said then, because there's medical information that would be important to say a transgender woman. Now I'm thinking that person could have a prostate, or that person might have increased risk of cardiovascular disease. So I think that it is appropriate to say it at the beginning, because really what you're trying to figure out is what's the physiology here when we're making presentations like that.
Thank you so much.
Let me give one caveat to that, though. The only thing I would
Yes.
say about that is, assuming that this is a closed and respectful space where the focus is on caring for the patient, because we don't want to out the patient without their permission. But let's assume this is nobody shares any of this information. This is medically safe. In that circumstance, it is medically appropriate to know if somebody is transgender, because their physiology is different.
That makes sense. Thank you so much for that thoughtful answer. We had another question, and I think it does tie into this safety component. So someone wrote, given the aggression we've seen from some state attorney generals, is it safe to give diagnoses of gender dysphoria or otherwise identify patients as trans in the EHRs?
Yeah, that's a unfortunately great question too. I think that probably the best approach is to ask the patient. And I think that comes up in other ways too. You know, physicians who go to a psychiatrist, for example, sometimes will say, please don't submit this to insurance with that diagnosis of depression because I don't want that out there. But yet another physician might say, well, I want insurance to pay for it, so yeah, go ahead. That's the decision of the patient. I see this in the same way. I think you could say, look, if you want this to get covered by insurance, I'm going to have to give a, a code, and this is the code I would use. How do you feel about that? And have that be part of the conversation with the patient. And maybe if they say no, absolutely not, you could instead code for anxiety or depression or insomnia if they're having trouble sleeping because of their stress, etc.
Thank you very much. What if the patient is a minor?
That is a great question. Um, I don't know that I 100% know the answer to that question. I know that for sexual health, you can take care of a minor without their parents' permission. But this might not necessarily be a sexual health conversation. I think if it includes sexual health, then from that perspective, you would say I can have this conversation with a minor. Um, Other than that, that's a great question that I'm not sure I know the answer to. I do know that there are clinics that see minors and that there is a terribly high suicide risk in minors who have gender dysphoria. So as always, I mean, even in taking care of anybody who's having sex before they're 18 and afraid to tell their parents, it was always my habit to talk to the person first and say, can we bring your parents in? And can we bring your mom in if we have this conversation together? Do you feel safe with that? And sometimes that would be okay. Like they were afraid, but they didn't really think it would go badly. They just didn't know how to address it. So that would be one thing I would offer. It's really important for your mom to know who you are. Would you feel safe if she did know who you are, if I helped facilitate that conversation and see how that goes? If they really feel like, no, they're going to hurt me or kick me out of the house, then probably I would ask some questions about sexual health and make it be a sexual health visit, in which case I'm allowed to see a minor. That's probably what I would do.
Thank you very much for your answer and for all your answers to our questions today. Thank you too for everyone to stick around with questions. We really appreciate it. Dr. Chiaramonte, we had someone say in the chat that they're just so impressed by this humane talk, and I think it's clear that your knowledge and your compassion comes through. So thank you very much.
Thank you for that.
We will maybe stick around on the call for just a few more minutes if anyone else has questions. Otherwise, thank you so much for attending.
Thank you
The
all.
recording for the webinar will be sent out. We will also send out Dr. Chiaramonte's slides. But thank you so much for your time and have a great day. Dr. Chiaramonte, if you could stick around for a minute,
Of
that would be
course.
great just to answer
Sure.
some other questions. But thank you very much. I just saw one question pop up right at the end that I wanted us to get to for anyone who had time. And the question was just about what if the university at which you teach forbids you to talk about this issue? Unfortunately
Oh,
true, but yeah.
gosh, I wish I had a magical answer for that. I don't, society's a little crazy right now. My general feeling is that what happens in the exam room between you and your patient is private, and I'm assuming nobody's listening in. But if a physician feels like there's real risk to them, I understand that too. I know that around reproductive health, people are struggling with that in some states as well. There's always a balance between serving your patient and taking care of yourself. And I can't answer that for you. I would say if you are not allowed, but there's no big consequences, then you could consider what you privately talk about in your exam room. If there are really, truly huge consequences for you, it's okay to prioritize your own well-being as well.
Thank you very much. That was the last question I saw. So any other questions can be submitted to customersuccess@mheducation.com.
Thanks,
Thank you
everybody.
again for everyone's time today. Have a great day. Bye.